Evans, and tonight we're privileged to have Mr. Krishna Vemulapalli, who's a consultant orthopedic surgeon in foot and ankle surgery. He works at King George Hospital in Goodmayers and Queen's Hospital in Romford, where he specialises in foot and ankle surgery and orthopedic surgery for children. He did his foot and ankle surgery training in Norfolk and Norwich Hospital and in children's orthopedic surgery at the Royal London Hospital. He also teaches surgeons in various orthopedic and FRCS examination courses. This evening we have Ruth and Hannah from OR UK, and the mentors this evening are Kashif, Shwan and Imran, as well as myself. Following the presentation, we're going to go for the MCQ tests, and we'd like you to answer those as quickly as possible, and then we'll take questions from the participants. If you have any questions during the presentation, if you put them in the chat box, we will monitor that and we'll ask at the end of the presentation. After all the questions are finished, we will stop the recording and we'll move on to the Viva practice. If you would like a Viva, we ask that you raise your hand or let myself or Ruth know, and also when you're sitting the FRCS Part 2. So without any further ado, I will pass you over to Mr. Vem for the presentation. Thank you.
Thank you, Nikki. Thank you, Ruth and OR UK. My name is Krishna Vemulapalli. I've been a consultant for the last 13 years. I work in Queen's and King George Hospital, northeast part of the London there. Thank you for inviting me to talk about foot and ankle. Before we go into the foot and ankle examination, I just want to say that I've been doing this for the last 13 years. However, I do this face-to-face, and I usually bring patients, and I demonstrate my examination skills and fine-tune my registrars and everyone. I am very, very particular about my examination findings, and all my registrars who has gone through the training know about the importance of this examination. So we have 26 bones, just a touch base on the anatomy. We have in each foot there's 26 bones, 33 joints, more than 100 ligaments and tendons. Foot and ankle examination is largely similar to any other joint examination, which is look, feel, and move, and then followed by special test. Every person has their own way of examining the foot and ankle, and this is my way. And what I say is, it is foot and ankle examination made easy. Like any joint examination, foot and ankle examination is an art. It can be painful and scary, or to do the examination, and the only way to get over it is you need to know the anatomy. If you know the anatomy, and if you are king of anatomy, then it is going to be a simple art, and it will be powerful and effective. The aim of the foot and ankle examination is to find out the pathology. It's like a bit of detective work there. Unlike a hip or a knee, I have a disadvantage that I have 26 bones, 33 joints, and more than 100 ligaments and tendons there. So I have to be meticulous, and even though it is looking like a duck, quacking like a duck, I don't believe that it is a duck, because it might come and bite me. So I have to poke it and see whether it is a duck or not. It's a detective work. What exactly is happening there? Because I don't want to bark at the wrong tree. And if I am barking at the wrong tree, as a surgeon, I have lost the game there. So the aim of this talk is to find out the pathology from the history and examination. So this is the most important thing. Each and every time my registrar changes every 6 months, they will be given the instructions. Each and every new patients, they have to take history, and with the history, they should be coming with a differential diagnosis of about 3 or 4. And then they have to do the examination and knock off 2 of the differential diagnosis, then only refer the patient to the investigations so that we will know exactly what is happening over there. And so to take the history, we have to go back to the basics, like what we did in our medical school, the 9 characters of the pain. What exactly has caused the pain? Was there any history of trauma, anatomical location, type of pain, whether it is radiating into the toes or whether it is radiating into the leg? Is it associated with shoe wear, or is it also there with bare feet? Is it more on uneven floor or even floor? Is it there with closed in shoes or even open top shoes? Was there any kind of pain while you are walking, standing, or whatever it is, running? Is how long do you need to walk to get the pain? So quantifying the pain. What are the alleviating factors? Is it like taking off the footwear? Does it help you? Or taking painkillers or taking rest? Then the special characters like startup pain and early morning pain. Once you know all these things, it will make your life easy. Before you touch any patient, you have to expose the patient until the knee. And if possible, you can go above it, but definitely it is mandatory to expose the limb. And it is not one limb, it is both the limbs. And then you have to look for any kind of walking aids around it, whether the patient has walked with a crutch or a frame, whether there is any kind of surgical shoes, insoles, or any kind of orthosis there. And then you have to start looking at the gait. You comment on the gait from the front, standing in the front of the patient, how they are walking, whether they are using any kind of orthosis or they need any kind of help, and then comment on their pelvic tilt, they comment on their gait. And then you comment the gait from the side. What are the rockers? How is the first rocker, second rocker, third rocker? The movement of the knee, movement of the hip. And then if they are able to walk without any aids, then I always ask them whether they can walk with their tiptoes. The reason why I ask them to walk with their tiptoes is because within 2 seconds, I will know about their ankle flexibility. I know about their midfoot functions, if there is any stress fracture, if there is any MTP joint synovitis, and also very quickly S1, S2 function as well. Then I will ask them to walk with heels. So again, ankle mobility, tibialis anterior function, EHL and EDL functions. If they have plantar fasciitis or heel problems, they will not be able to walk on their heels. And also we are checking L4 and L5 nerve root there. Walking on the outer and inner aspect of the feet. So I can assess the subtalar joint. I can see whether there is any medial or lateral gutter impingement, if there is any first ray problems or fifth ray problems over there. So once we have looked at the gait and everything, then comes the looking. So you have to always look from the whole of the lower limb. How is the alignment of the lower limb to the hind foot? How is the midfoot to the hind foot and forefoot and toes? Because you can easily miss something which is above the knee if you are just concentrating on the foot and ankle. Once you rule out that there is nothing, no problem with the alignment, then you look from the front, you look from the side, that is inner aspect, you look from behind. You need to go around the patient, and then you look from the outer aspect of the foot. Please do not forget to look underneath, because that might be the pathology what the patient is having. Once you have taken the history and then inspection, then you know what exactly is the problem, or where is the problem. So then you tailor your examination, rest of the examination, depending on your history and inspection findings. There is no point of doing Coleman block test for a flat foot, and vice versa, doing a too many toes, commenting on too many toes, or single foot tiptoeing in a in a pescavers. So you need to tailor your examination from here onwards, depending on what do you think is the pathology. So the best position of examination is patient sitting in on an examination table, and you are sitting in a chair and the foot is to your elbow level. So by doing this, patient is comfortable and you are also comfortable there. First and foremost, before you touch the patient, you ask where exactly is the tender point. Once you know that where the tender point is, try to examine that tender point at the last point in your examination. You check your feeling with your temperature. Then, as I have clearly said, that you need to know the anatomy. If you know the anatomy, that the life is really easy. You need to keep looking at the patient's face, but your fingers has to do the work. You need to know where your thumb, where your index finger is, whether it is on the medial malleus, whether it is on the tibialis anterior, EHL, whatever it is. You need to have a systematic palpation. If you want to come from the top to the medial side, it is entirely up to you. Whether you want to go from inside to outside, whether it is entirely up to you. But you have to develop a type of systematic palpation. Inside, what exactly you are looking for. Outside, what are you looking for? And then posteriorly, and on the plantar aspect of the heel, on the top of the metatarsals, and also underneath on the metatarsal pad. So these are the points where you have to look and feel for the palpation there. Depending on the location of the pain, depending on the tenderness, you have different pathologies which are illustrated on this tabular form. Then you start your movement. I always start the movement with Silver-Skjold's test. By doing this thing, I will know whether the Achilles tendon is tight because of the gastrocnemius part or the soleus part of the Achilles tendon. Then I will start moving the ankle, subtalar, tarsal, chopper joints, and metatarsophalangeal joint. Remember, supination is a complex movement of inversion, adduction, and plantar flexion, and pronation is eversion, abduction, and dorsiflexion. So this tabular form will tell you what are the possible causes of restriction if you have dorsiflexion, plantar flexion, inversion, or eversion restrictions over there. This is a picture where I'm demonstrating the Silver-Skjold test. On this picture, I have flexed the knee so that the gastrocnemius is relaxed, and I could get this much of dorsiflexion. And with the dorsiflexion with my right hand in the same position, I have straightened the knee. As soon as I have straightened the knee, you can see that the patient can't have that much of dorsiflexion. So this patient has a gastrocnemius tightness over there. Once I do the movement over there, then I'm going to go now special test. Each and every muscle has to be tested there. The first muscle which I usually do is tibialis anterior. You don't need to follow this regime, but this is what I do. And for doing that, the ankle should be in dorsiflexion and inversion, so that I am isolating only the tibialis anterior, and I don't get any kind of power or movement from the tibialis posterior. So once I get the ankle in that movement, then I will ask the patient to hold the foot in that position, and with my right finger I'm trying to pull it down, and with my left finger I'm feeling the power and the contractions in the tibialis anterior. Tibialis posterior, the foot ankle should be in plantar flexion and inversion. So my left finger is on the tibialis posterior aspect of the medial malleolus, and on the right finger, I'm trying to push it laterally. So a bit of close-up of picture. So this is my finger on the tibialis posterior, and you can see that over there, and I'm trying to push that foot away from my my hand there. Peroneal tendons, again, the plantar, it is plantar flexion. You need to have the foot in a full plantar flexion and eversion. And with my left hand, I'm asking the patient to push my left finger, and then I'm feeling the peroneal tendon. So you can see the, not only you can feel it, but you can also see the strength of the peroneal tendon over there. EHL and EDL, again the same thing, asking ankle in a neutral position and then trying to pull it up, and EDL is again trying to pull it up there. The FHL and FDL slightly in plantar flexion, and then asking the patient to push the big toe or the lesser toes over my fingers there. So once I do the power of these tendons, then I will go, depending on the patient's history, if the patient is complaining of any kind of giving way, then I will do a anterior draw sign. If the patient has pescavers, then I will be doing Coleman-Bock test and peekaboo sign. If there is a flat feet, I will be looking at the too many toe sign or single leg tip toe test. If I'm seeing a diabetic patient, so I will do a semi-Swinstein monofilament test. So anterior draw sign, let's assume that there is a patient who is complaining of giving way. Patient sitting high up on the examination table, foot in slight plantar flexion, and I'm a right-handed, so I am holding the the heel with my index finger and with my long finger in the back, and then I have the thumb in the front, slight plantar flexion, and my left hand is holding the tibia. So then what I'm doing is I am pulling in the direction, slight plantar flexion and anteriorly. It is a similar test like what we do for the ACL in the knee. So this is again one more picture demonstrating that is holding the tibia, plantar flexing, and then that is the direction, anteriorly and slightly plantar flexion there. Then what you will see is a bit of sulcus sign, that is the skin getting sucked inside on the lateral aspect, and also you will see a bit of movement over there, and always compare with the opposite side. And sometimes you can hear, if it is significantly unstable, you can hear and feel a clunk. That is the anterior draw sign there. If there is a possibility of a syndesmosis injury because history of trauma and everything, what I do is syndesmosis stress test, which is holding the leg with my right hand, dorsiflexing the foot and externally rotating. I'm stretching the syndesmosis over there. You can do this test by standing. I will also do this test in a standing position, that is weight bearing. I will ask the patient to stand up on one leg and twist the body so that we know what exactly, whether we are having any stress, pain in the syndesmosis there. This is the diagrammatic, again, representation of what I do. And then comes to the too many toes sign. This is mainly for the tibialis posterior dysfunction when there is a hindfoot and midfoot invalgus. Normally, if you are looking at the foot from the posterior aspect, you should see the little toe or half of the fourth toe. If you see more than 1.5 toes from the posterior, that means too many toes sign positive. So you can see here, little toe, fourth, third, second, and a bit of big toe. That means this foot is collapsed medially, and there is a hindfoot valgus there. So here also you can see a lot of toes here, and you can see that is a big toe and the rest of the toes. So this is all hindfoot, midfoot, and forefoot valgus there. Then comes the single leg tiptoe test. So you have to take a patient to the wall and ask him to take the support of the wall, standing 1 foot away from the wall, standing on a good side, and by taking the support of the wall, he can, you ask him to go on tiptoes. He has to stay on tiptoe for 30 seconds and then swap it with the pathological side or the painful side. Some people does this holding the chair. That is completely wrong, because if you are holding a chair and going on the tiptoes, that means you are using your upper limb to push your body in the air. So I always recommend to get this done holding the wall. This is a peekaboo sign. So it is like if you have a child or a nephew, whatever, whoever is a child, you play with your child like a peekaboo. So on the right side here, you can't see any heel. So you should not be able to see any heel if you are looking at anybody's feet. If you are seeing a bit of heel there, that means calcaneum is playing a game with you, like a peekaboo game. So it is like that game which we play with our children. So this is where you have significant hind foot varus, and you can see the arches which are high there. Now comes the Coleman block test. This is mainly meant to find out if the hind foot is flexible, whether the hind foot varus deformity is driven by the forefoot. So how do we do it? The peroneus longus is very, very strong. So what it does is peroneus longus is attached onto the base of the first metatarsal. So it pulls the first metatarsal down, and because of that, the whole forefoot is in slight pronation. To compensate that, you completely turn your hind foot into varus. So the hind foot is driven by the forefoot plantar flexed first ray. By doing the Coleman block test, where you are taking off the first ray and the second ray off the block, then you will correct the hind foot deformity. This is the hind foot which is in varus. The patient is standing on a block. So we have neutralized the peroneus longus and the plantar flexed first ray, and you can see that the hind foot is completely corrected. This is the textbook pictures, and you can see that there is a peekaboo sign over here. The foot is in varus bilaterally, and you put the Coleman block test. First and second ray, or maybe the third ray, is off the Coleman, and you can get the heel which is very straight compared to the opposite side, which is in varus there. The last special test is semi-Swinstein monofilament test. So this is a 10 grams monofilament, very sensitive, and you need to push it. You need to push it so that there is a bend in the monofilament, and if the patient is able to feel the sensation, that means that there is a pressure sensation intact. If the patient cannot feel the sensation, there is a high chance that this patient is going to develop ulcers there. So complete the examination by prone, in the patient in prone, or kneel down there, where you can examine the lower end of the spine, and also you can see the plantar aspect of the foot and the neurovascular examination. So that is, in short, a synopsis of how I examine my foot and ankle. So I will wait for any questions now, then we will go for some case discussions. Oh, sorry, actually, hang on. We have some more slides. Hang on there. So these are the slides which I want to show you, common cases for the FRCS. So this is obviously hallux valgus or hallux rigidus. People who usually miss, I'm just making a box because I usually bring the patients and ask one of the registrar to present, because there is no patient to be presented. I'm just giving a box of information where people keep forgetting to, or forgetting to mention these things, or some of the important salient features which examiners expect you to comment on. So don't forget about walking aids, shoes, and any kind of orthosis gait. Then you comment not only on the big toe, you have to comment on the lesser toes. Don't forget about plantar callosities. Think about sesamoid tenderness in the hallux valgus or hallux rigidus foot and ankle examination. Talk about the flexibility and the movement of the joints, because if there is no movement, that means it is hallux rigidus. If there is movement, then that means it is hallux valgus. And also whether you can correct it or not. Then at the same time, you have to think about whether the forefoot deformity is a compensatory deformity because of the midfoot or hindfoot. For example, tibialis posterior dysfunction, where there is a pronation deformity and a collapse of the middle arch, they will be compensatory hallux valgus. So if you are doing a hallux valgus surgery in a tibialis posterior dysfunction, it is going to fail. It's the same thing. One of the common reasons of hallux valgus is Achilles tightness. So you need to do the Achilles tendon examination for complete sake of hallux valgus pathology. Don't forget that 60 to 70% of these patients who has this much of hallux valgus deformity will have loss of sensation there. And watch the face always when you are doing the palpation. This is the second commonest case in the FRCS, tibialis posterior dysfunction. So these are the things which you should not forget about talking about in the tibialis posterior dysfunction: walking aids, shoes, orthosis gait, too many toe sign, 1 foot tiptoe test, which we talked about. Achilles tightness, this is one of the commonest cause of tibialis posterior dysfunction also. When you are, because this is basically because the midfoot is collapsed. When you are trying to examine a Achilles tendon tightness or doing a silver scales test, don't do it without locking the midfoot in the supination. Otherwise, what you are getting is a dorsiflexion movement from the midfoot. And the rest of the things are, don't forget about examining the alignment of the knee, because there might be a genu valgum, and the foot pronation deformity and the tibialis posterior dysfunction is secondary to the valgus deformity of the knee. Again, please keep watching the face of the patient. Then the next commonest thing is pescavers. And in this one, again, walking aids, shoes, orthosis, please don't forget it. And shortcut foot, pescavers in this country and most of the Western countries are shortcut merit tooth syndrome. So they will have some kind of hand intraosseous muscle wasting. And so please examine before you go to the foot and ankle so that you have completed that, and that is a passing tick box exercise. Look at the comment about the peekaboo sign. And these patients have weakness of tibialis anterior. So they will have a foot drop type of gait where there is no heel contact as an initial contact there. And you will have a compensatory clawing of the toes. Basically, because the tibialis anterior is weak, the patient will be recruiting the EHL and EDL to do the dorsiflexion. There is an inverted champagne bottle calf muscle. Because the patients walk on the outer aspect, you will have callosities on the 5th metatarsal, and they might have 5th metatarsal stress fractures. And don't forget about Coleman block test. And these patients might have lateral ligament insufficiency. So try to do anterior draw sign. Some patients will be coming to you with 5th metatarsal stress fractures. Sometimes they will have giving way symptoms, instability signs. So look at the lateral ligament insufficiency. Tibialis anterior and peroneus brevis is very weak compared to the tibialis posterior and peroneus longus. So you need to examine all the 4 muscles there. Don't forget to examine the lower end of the spine, because this is a neurological pathology unless proven otherwise. So finally, my foot and ankle examination is history, and examination, and then we will confirm the diagnosis what we have done by investigation. The first question is ideal position of the foot and ankle while testing the tibialis anterior power. So we know that the tibialis anterior and the dorsal tendons, which are EHL, EDL, and peroneus tertius, which is in the anterior, and the tibialis posterior, which is on the medial side, can cause some kind of inversion there, and the dorsiflexion. So to neutralize the tibialis posterior, then you need to put the foot in full dorsiflexion and inversion. So by doing that, you are neutralizing and isolating only tibialis anterior. So the answer for the first question is dorsiflexion and inversion, where 95% of the people who has got correct. Some people have voted neutral and inversion, and the other one, some people have voted plantar flexion and eversion. So these things, you do not get the tibialis anterior into the isolation thing. So in the same context, ideal position, second question is ideal position of foot and ankle while testing the tibialis posterior. So you need to again now neutralize the tibialis anterior. How are we going to neutralize the tibialis anterior? If you put it on the maximum stretch, the maximum stretch is in the plantar flexion and inversion. So by doing that, you are isolating, you are getting only the power of tibialis posterior. So the answer is plantar flexion and inversion. So again, 90% of the candidates got it right there. Coleman block test. As I have mentioned, that Coleman block test will check, first of all, whether the hind foot is driven by the forefoot and whether the hind foot is flexible or not. So first and foremost, if it is because of the peroneus longus hyperactivity, and the Coleman block test will confirm that the hind foot will be correcting, we will correct the hind foot varus deformity. For example, if the hind foot has varus, so patient is old or had been there for a long time, and there is arthritis in the subtalar joint, even if it is forefoot driven, you will not be able to correct the hind foot varus. So that's why the answer is forefoot driven flexible hind foot varus. It is not fixed hind foot varus. Thank you.
Thank you very much, Krishna, and thank you for your talk. I think that was a really useful talk for the candidates, because it's quite likely that you'll be asked to examine somebody's foot and ankle in the exam, and that was lots of good tips for your clinical examination, which, you know, we've not had the benefit of all the courses that we normally would to practice. So I would watch that again and just make sure that you can familiarize yourself with those techniques. So what we're going to do next is move on to the questions from the audience. I think Hani and Imran were looking at the questions.
Yeah. Is Omar Ahmed said, if the patient has more than 10% of dorsiflexion, but it increases on knee flexion, is this to be considered as positive Silver's coil test?
So if there is 10% of dorsiflexion and it is increased by flexing the knee, is that correct? Well, the thing is, the normal dorsiflexion varies from 10 to 20 degrees. So if it is same as the opposite side, then it is positive. If it is same on both sides, then the patient has that much of dorsiflexion. So it is always comparison with the opposite side.
Okay. Mehdi, so he asked, do we need to test the peroneal longus muscle power in plantar flexion of the first rail?
So what I have said that is peroneal muscles. I did not isolate peroneal longus and peroneal brevis over there because it is a bit difficult and I have to demonstrate face to face, but I can't do it on this one. That's why I put it as peroneal muscles. So if we are doing the peroneal muscles, that is usually the eversion. A combination of peroneus longus and brevis will cause eversion. And you need to neutralize the peroneus tertius. So the peroneus tertius is attached on the dorsal aspect of the fifth ray. The way to isolate the peroneus, neutralize the peroneus tertius is putting the patient ankle in a plantar flexion, so it is maximum stretched, and what you are testing is mainly the peroneus brevis. That is what it is.
Okay, so
from Milindu.
How we can examine spring ligament, please?
Spring ligament.
Yeah.
Right, so this is the spring ligament. There are different tests which have been mentioned, but there is no clear-cut complete specific test for that. One of the things is that you hold the foot in neutral and then try to do the valgus with one finger. You push the forefoot into valgus. If it stays there and it is not springing it back into the position, there is a complete tear and there is a insufficiency of spring ligament. It is, again, we have done that research on the cadavers. In some cadavers, it was positive, and in some cadavers, it is not positive. But it is 50-50%, and it is difficult to isolate the spring ligament on its own.
Okay, so another one. So if we have a rigid hind foot varus and plantar flexed first ray, how to differentiate the origin of the hind foot varus?
Well, it is, I think if you have a rigidity in the hind foot, it is now more of a bony procedure. We can't do any kind of soft tissue procedure. The reason why we need to do that is whether it is a flexible deformity or a fixed deformity. So that is again the orthopedic principles. If there is a flexible deformity, you try to do the soft tissue reconstruction. If the patient has a bony rigidity or a fixed rigidity, then you have to do the bony procedures. So that means that differentiating is going to be difficult, and we don't do anything because the patient needs a bony procedure like subtalar fusion with or without calcaneal osteotomy.
Okay. So
another question: if the
yes.
patient has fixed flat foot, how can I lock the transverse tarsal joint to test the ankle range of movement?
So if it is actually, it is going into the fixed valgus, usually trying to do a supination will lock the midfoot and the TMT joint. So that is how the gait is. So you try to supinate the midfoot and forefoot and see whether you can dorsiflex the ankle. If there is any dorsiflexion, that means you are getting the movement only from the ankle joint. If there is no dorsiflexion, that means it is there is arthritis in the ankle and you don't get any movement in the ankle joint there.
Okay,
Next
so the last question. How we can confirm flexibility of the heel in stage 2, 3, 4, tibialis posterior insufficiency?
4 is arthritis, pan-talar arthritis. 3 is subtalar this thing. So it is only the 2. So that is the tibialis posterior dysfunction classification is when you have 1 and 2 is the flexible thing.
He said, what are the different investigations that we can request in foot problems? This is from Muhammad Javaid.
Well, it is a big open question. So we can start from X-rays, ultrasound scan, MRI, CT scan, and the bone scan. And some of the cases which are very complex pathology where we do not know which is the culprit. And if we have 2 or 3 differential diagnosis, even after the MRI scan, I go for SPECT CT. That is the highest scan. And I also do a diagnostic injections. These are really very good because it will tell me which joint is the pathology. So if I think that there are two joints which are pathology, for example, navicular-cuneiform joint and Tailor navicular joint. So I will try to isolate one of the joint by giving a steroid injection or a local anesthetic into the joint, asking the patient to keep the pain diary. I use this regularly for before I take the patient to the theater for ankle replacement or ankle fusion. I try to find out whether the subtalar joint is involved or not by doing an arthrogram and injection into the subtalar joint, asking the patient to keep the pain diary. And if the patient has no pain improvement, that means all his pain is coming from the ankle joint. So those are the diagnostic investigations we do.
Okay, just one last question, I think, to clarify. I know you mentioned about supination, foot supination and foot pronation. Somebody is asking whether supination is a separate movement, but I know that you mentioned supination is a composite movement, pronation is a composite movement.
Yes.
If you can clarify, please.
So supination is a combination of inversion, adduction, and plantar flexion. Pronation is a combination of eversion, abduction, and dorsiflexion. The best thing you can do is where you are sitting, whoever has asked this question, where you are sitting, look at your foot and try to put the foot in inversion, plantar flexion, and it auto, as soon as you put your foot in inversion and adduction and plantar flexion, that is the supination. That's what it is, supination. If you are dorsiflexing and trying to move your little toe towards the proximal part of your body, so that is abduction, eversion, and dorsiflexion. That is what supination and pronation is. Try to feel yourself. Look at your foot. Put your foot in inversion, adduction, and plantar flexion. That is supination. Put your foot in eversion, abduction, and dorsiflexion. That is pronation.
Thank you.
Okay, that's great. Thank you.
Thank you.
So we're going to move on to some case-based discussions now.
Yeah.
And I think Ruth has got a couple of volunteers that it's not quite a Viva, but we're going to discuss it, and you've got the opportunity to talk through it. Yeah.
Yes, Joe's going to just do the first case discussion with Krishna.
Okay.
Yes, hello. Hello, Ruth.
Hi, Joe is there?
Yes,
He is.
I'm here.
Okay,
Can you
Joe.
see me and hear me? I don't know.
Yeah. Hi, Joe.
Yeah.
So
Hi.
this is a 30-year-old female complaining of foot pain. History of stepped into a pothole while playing with nephew in the garden. Pain and swelling in the foot, unable to weight bear. What is happening in your mind if you hear this story? What do you think are the possible pathology here?
Okay, so the traumatic, so fracture, stress fracture.
Joe.
Sorry?
Stress fracture,
No,
you say?
no, sorry, not stress fracture. Traumatic fracture of the foot.
Foot is 26 bones, Joe.
Okay. Well, I can't. The pain and swelling in the foot, it's not in a specific part. So I need to take more history about where is the pain.
I just want to stop you. There is something very important in the history, which is a pothole. Does it ring bell? Does it make you worry about it?
Yes, I'm worried about that. It might cause a ligamentous injury from an inversion, from an inversion injury to the ankle.
Let's stop. Sorry. This is the foot.
Okay.
And you want to see from the plantar aspect, this is what it is. So what do you think is happening?
So there is ecchymosis on the sole of the foot, and my worries here is that there might be a ligamentous injury to the Lisfranc ligament, and this might be a Lisfranc injury. due to this ecchymosis. I want to sorry.
So this is not a viva, so I will stop you there. Okay.
Sorry.
So this is unable to weight bear, midfoot grossly swollen with ecchymosis, tender on palpation of the midfoot. Okay, I'm going to just run through. That is correct, the Lisfranc's fracture. This is the X-ray which we have over there. Okay. Now, the Lisfranc's fracture is not just the ligament injury. The Lisfranc's joint is any bony or ligamentous injury in the first, second, third, fourth, and fifth TMT joints. This is the Lisfranc's thing. So if there is a disruption between the intercuneiform over here, all of them is Lisfranc's joint and everything. So you do the X-ray, and then you need to look at the medial border of the medial cuneiform into the first metatarsal, and this is what you are looking on the AP view, lateral TMT joint, and the medial border of the second TMT joint. Then you will have to look at the space between the medial and intermediate cuneiform, and the first web space should match. On the oblique view, then you have to think about, so you look for the first TMT line, and the third medial border of the metatarsal shaft should match the lateral cuneiform, and again lateral border should match the lateral border of the lateral cuneiform, and the fourth metatarsal medial border should match the cuboid there. Then the spaces should match over there. Then on the dorsal side, there should not be any step. If there is a direct Lisfranc's, you don't look for these things there. The treatment for the Lisfranc's fracture, if you suspect the Lisfranc's fracture, there is no non-operative treatment unless the patient is taken to the theater and make sure that there is you do the EUA and the ankle and the foot is stable. Then only you do the non-operative treatment. Otherwise, it is a operative treatment, and the principles are stability of the medial column even at the cost of the restriction of movements. Every attempt must be made to reconstruct and preserve the essential joints. So what is non-essential joints? The non-essential joint is very little movement. That is first, second, and third TMT joint, intercuneiform joints over there, and naviculo cuneiform joints over there. And the essential joints are fourth and fifth TMT joint, calcaneocuboid joint, and Tailor navicular joint over there. Principle number 2 is proximal to distal. So if there is a cuneiform navicular cuneiform joint disruption, you need to fix that before you go to the cuneiform metatarsal. And then medial to lateral. So that is the second principle over there. So open, reduce, and fix the medial border of the medial cuneiform to the medial border of the first TMT. Then open, reduce the second TMT, open, reduce the third TMT, and then congruency of fourth and fifth should be checked and fixed with K-wires. So in principle, so in summary, first, second, three TMT joints should be fixed with a rigid fixation like with screws or plate. Fourth and fifth should be fixed with K-wires. So this is what is the main problem. If you see any kind of this X-ray like this, you don't want to see this at all in your life. So this is the last time you are going to see, and you are never ever going to see that. Never ever fix the Lisfranc's fractures with K-wires. Thank you. Who is going to take the second case? The case, 23-year-old, complaining of pain in the ankle, history of injury to the ankle while snowboarding. He's having difficulties in full weight bearing. That is the ankle. What is going through your mind with this thing? No X-rays, nothing. This is the history, and that is the clinical examination. Tell me, what do you think is happening?
Since that is a snowboarding injury, I suspect fracture sprain in the form of fracture anterior process of calcaneus or fracture of the lateral process of talus fracture.
Brilliant. Okay, so that is fantastic. So continuing the examination, he's unable to weight bear, grossly tender all over the lateral aspect of the ankle. Ankle movements and subtalar movements are very, very painful. TMT joints and Achilles tendon is normal there. That is the X-ray. What can you see?
Yes, the anterior radiograph of the ankle, I show displaced fracture of the lateral process of the talus. It's quite
Fantastic.
clear in the subfibular space.
That is the lateral process of the fracture, talus fracture. Unique structure in the talus because it articulates with the ankle and it also articulates with the subtalar joint. So if you have this fracture, you have two joints screwed up. One is the ankle joint and the other one is a subtalar joint. And it is called a snowboard fracture. The unfortunate thing is that 33% of these fractures are missed by us and also by the ANA. What you have to look for is you need to think about high index of suspicion. As soon as you think that the patient is having unable to walk and weight bear, don't think that it is a sprain. If the patient is unable to weight bear, that means that there is some kind of bony problem. Look and think about it. If you think about it, your brain, your eyes will look for it. If you think in your brain that could this be a lateral process of the talus, then your eyes will look for it. And what are you going to look for? It is called as V sign on the lateral view. I will show you in that. This is the classification. Type 1 is a small chip fracture. Type 2 is large fragment, whether it is displaced or not. And type 3 is comminuted and involve the entire lateral process. So here you can see that this is a skewed V here. And you should have a broad V like that. This is normal. If you have a skewed and V, it is bad. So what I say to my registrars is, people call me Mr. V in my hospital. So I am fat. So I always say fat is normal. And this is skewed or bent V is very bad. That is the best way to remember for all of you there. What we do, type 1 and type 2A, which is undisplaced, you fix them, and type 2B and 3, you do the fixation, or if it is mushed up, you just excise those things. So the diagnosis, if you diagnose early and treat properly, the patients will have better hindfoot score. Right, that is the second case. Who can take the third case then? 5-year-old, fit and healthy, training for marathon, complaining of pain, sudden onset with vague aching pain and swelling on the foot. No history of trauma. Able to walk and carry on his normal day-to-day activities. Pain increase with activity and progress worse to post-activity. What do you think is happening there?
Stress fracture.
Sorry?
Stress fracture.
Very good. So that is what it is. Normal range of movement, normal strength, diffuse swelling, no ecchymosis, local pain over the forefoot, tenderness over the second and third metatarsal, unable to hop. That is what is important. Unable to hop or go on tiptoes there. So that is the diffuse swelling. And when you do this X-ray, this is not the same patients, but you can see that there is already healing there. You need to think about why the patient had the stress fracture. Could it be sudden change in the activities? Could it be osteoporosis? Could it be because of poor conditioning that is suddenly locked during the lockdown? People have started going for long walks, sudden running and everything. So this is without conditioning, without training, that is what happens. Improper technique, change of surfaces. People who were doing indoor running has started going outdoor into the woods. That might have caused a change of surface. Improper equipment and excessive loading because of varus, valgus, hindfoot, or the knee problems. Treatment is activity modification, avoid high impact activities, and if they are still very painful, then you can put them in plasters there. Operative treatment is very rare, but if it goes into non-union, you can do that one. And if it is because of the biomechanics, then you try to do the gait analysis. Here the valgus foot is there, and by doing the insoles, you can correct that one, and you can address the biomechanics there. Thank you, Mohammed. 45-year-old, fit and healthy, commutes to work on motorbike, complaining of limp and difficulties, to change the motorbike gear, denies any trauma, no history of pain or swelling, notices more limp and frequent tripping with bare feet or flip-flops, feels comfortable with less limp with boots. What is happening? What do you think is happening, Mohammed?
I think there is some tibialis posterior, probably the tibialis posterior inflammation, which is causing the problem.
So what does the tibialis posterior do? What is the function of tibialis posterior?
Is plantarflex and invert.
Yeah, so this is, he is unable to, he can do it plantar flexion, but he can't do the other way around.
You cannot do the dorsiflexion.
Yeah.
So, Achilles tendinitis.
So what we have done is, I have looked at this thing. This is the foot, and inspection, there is a small scar where you can see the dots as shown, and there is no other abnormality. So I asked him to walk, and he can walk on tiptoes, but he is unable to walk on his heels alone. So what is happening?
Plantar fasciitis?
No. So this is a tibialis anterior rupture. The pathognomic sign of tibialis anterior dysfunction is inability to walk on his heels alone. Now, when I questioned him, this guy is a very big macho man. So he was saying that he was helping his wife, and he dropped a knife, and it went through that, and there was a small scar. He put some pressure on, and he carried on. So when he dropped his knife helping his wife, he has cut his tibialis anterior, and it was lying somewhere over there. So this is an inability. If the patient cannot walk on their heels, one of the commonest pathognomic thing is, you have to think, if the patient is able to do everything and suddenly he is unable to walk on his heels, it has to be tibialis anterior unless it is proven otherwise.
Thank you very much for excellent presentation. As always, FRCS Mentors is really pleased to work with OR UK in providing these webinar sessions. OR UK is a charity that's recognized in orthopedic research, but also orthopedic education. Their website has future webinars and also a number of courses and books. FRCS Mentor Group, as you all are aware of us, we are a large group of mentors that are passionate about teaching and preparing people for the FRCS. There's a Telegram group, Facebook and YouTube channels, and we also have Concise Orthopedics textbook over my shoulder if you guys can see my video. Thank you so much to our presenter today. It was an excellent talk.
Thank you.